Hi students, this is me Dr. Tiwari, and today I have come up with very important topic. Okay, especially in the United States, it's very important in clinical practice, and you'll be frequently tested from this topic. Although it is a small topic, but you'll be frequently tested, and you need a core knowledge about this topic. It's about pharmacotherapies for smoking cessation and opioid dependence. As always, my topics are especially for USMLE, PLAB or NCLEX students, and also it can be equally helpful for medical and nursing students at their medical and nursing colleges. Okay, so here we'll be talking about nicotine replacement therapy, Varenicline, Methadone, Buprenorphine, Suboxone, Naloxone, and Naltrexone. So let's begin with nicotine replacement therapy. So as always, we know that nicotine replacement therapy is given to those patients who has had nicotine dependence and is now under withdrawal. So those patients who are experiencing nicotine withdrawal symptoms, or let's say now trying to quit nicotine, and in that case we give them this replacement therapy. Replacement therapy can be either long acting or short acting. Long acting includes patches where you put the patch on the skin and that works for 24 hours or more, and there are also short acting ones like gum, lozenges, inhaler, nasal sprays, and sometimes obviously the combinations of both of these can be used, like patch and short acting, for breakthrough cravings. So this nicotine replacement therapy we give to the patients who are on trying to quit the nicotine, okay, so that the withdrawal can be prevented. And this mechanism is that it binds these things, nicotine replacement therapy, this bind to nicotinic acetylcholine receptors and relieves the withdrawal symptoms. So now these things, they bind to nicotinic acetylcholine receptors and they just help to get relief from the withdrawal symptoms. It doesn't produce euphoria. This is important, okay? It just helps to prevent the withdrawal symptoms but doesn't produce the euphoria. So there are some adverse effects of this nicotine replacement therapy, like they can cause you headache. If this is a patch, then it can cause you skin irritation. They can cause you oral irritation. However, if you compare through the risks and benefit eyes, then we can say that it is safer in pregnancy. Okay, rather than smoking, you can choose nicotine replacement therapy in pregnancy. So again, we have to remember that these are given especially if the person has mild or moderate dependence, then this nicotine replacement therapy is given. We also need to give them cognitive behavioral therapy, counseling, good counseling. Next is that is Varenicline. This is a drug which we prescribe for nicotine dependence syndrome. So here we have to remember this mechanism of actions. Out of this alpha 4 beta 2 subunit, this can serve you as a hint to pick up this drug in your examinations. Okay, these questions I have also added as down as a model question for you, so you can go that later. Now Varenicline, it acts as a nicotinic acetylcholine receptor partial agonist. This is a partial agonist. It is acetylcholine receptor partial agonist, and it acts on alpha 4 beta 2 subunit of acetylcholine receptor. Next is that it acts as a since it is a partial agonist, it reduces the withdrawal symptoms of nicotine. It also acts as a competitive antagonist, so it's both the partial agonist as well as competitive antagonist, and blocks the because of it is competitive antagonist, it also blocks the nicotine reward symptoms. Also it decreases dopamine and blocks the reward symptoms. Also dopamine is released in nucleus accumbens. So from this Varenicline, as long as mechanism is concerned, you need to know that Varenicline is especially used in nicotine withdrawal syndromes, and here to the nicotine dependence patient, and it acts on the alpha 4 beta 2 subunit of nicotine acetylcholine receptor, and it works as a partial agonist, and that helps to reduce the withdrawal. And it also acts as a competitive antagonist, and that blocks the nicotine reward symptoms, also decreases dopamine release in nucleus accumbens. This you have to remember, okay? And Varenicline, it has adverse effect, like it causes GI discomfort, so we give we ask the patient to take some food and water along with these drugs. And it also helps it also causes sleep disturbances and vivid dreams. So Varenicline, we can remember this by this hint, alpha 4 beta 2 sobinate, and also vivid dreams. Okay, this has been asked in the examinations. So what is the side effect of Varenicline? Then you have to know, pick the answer, vivid dreams. So next is we also need to monitor for neuropsychiatric symptoms, because it has a black box warning for suicidal ideation and depression. Okay, this is another important thing to know. Key benefit is most effective single agent for smoking cessation. So it's better than nicotine replacement therapy because it's highly effective, and you have to start 1 week before you're quit date. This is another hint to remember. So there are lots of hints that you need to remember from this Varenicline around. Alpha 4 beta 2 subunit, partial agonist, competitive antagonist, GI disturbance, sleep disturbance and vivid dreams, black box warning, and also start 1 week before quit date. These all things can serve as a hints for examination. Okay, yes, step 2 and 3 poll is that you have to ask about psychiatric history before prescribing. Now let us know about, we studied about nicotine replacement therapy and Varenicline from the nicotine withdrawal symptoms, okay, and their management. Now let's learn about opioid withdrawal symptoms, and then we'll try to learn about their management. So we know that opioid withdrawal symptoms, it presents with anxiety, yawning, rhinorrhea, pyeloerection, diaphoresis, mydriasis, salivation, lacrimation, urination, defecation, mydriasis, again I said it here, and emesis. So these are the symptoms of opioid withdrawal. Okay, we have to remember that opioid withdrawal is not a life-threatening condition, unlike alcohol or benzos withdrawal. And if a person is having excessive symptoms of this excessive autonomic symptoms as a result of opioid withdrawal, we can always prescribe them clonidine. Okay, this is for symptomatic control. Clonidine is for symptomatic control. We have to remember this as extra part, that if a person is using injection then as a drug for drug abuse, then it may lead to infective endocarditis, and tricuspid valve will be affected, and staphylococcus aureus is often the culprit. Now this chart is very, very important for the examinations. Okay, this is head-to-head comparison for opioid pharmacology. So we know that to prevent the opioid withdrawal symptoms and its autonomic symptoms, we give clonidine, but to challenge and to prevent the persons from the opioids intoxication or opioid let's say cravings later, in the later part of the time, we have to know about these drugs. These are methadone, buprenorphine, Suboxone, which is a combination of buprenorphine and naloxone, and it's a naloxone and naltrexone. We have to be master in this 5 or 6 drugs. Okay, so methadone, let's begin with methadone. Methadone is a full mu opioid agonist. Okay, it is also an NMDA antagonist, so you have to know this mechanism action. Methadone, it's not a partial, it's a full mu opioid agonist, and it is also an NMDA antagonist. Methadone is always given in case of in a licensed OTP clinic. Okay, so there are some federally licensed clinic in USA, and only those clinics under the supervision of the doctor. In this clinic there are other multidisciplinary team already ready. Okay, so only in those conditions you can treat this treat the patient with methadone. And oral drug formulation can be used, and key indication is again opioid use disorder maintenance, and sometimes for chronic pain management also methadone can be used. Your side effect is that QTC prolongation. So before prescribing methadone, you have to see the baseline ECG and to just to be sure that there is no any QTC prolongation. Okay, it can cause, methadone can cause respiratory depression, constipation, and you don't need to avoid in pregnancy, but it's it's relatively safer in pregnancy. Yes, here at this point I want you to just get this message. Okay, yes, instead of avoiding in pregnancy, let's say if you have to choose, methadone is a full opioid agonist, so it's not always it's always, you don't need, it's not a good choice to take methadone at all. But if for combating the opioid use disorder, if you have to choose for, let's say methadone, then out of any of this drug, methadone is safer in pregnancy. Okay, so it is, let's write here, relatively safer in pregnancy. Next is it's, we had read this earlier, only dispensed at federally licensed clinic, and we have to remember that methadone can develop drug interaction by cytochrome P3A4 mechanisms. Okay, and next is we are trying to learn about buprenorphine. Buprenorphine is a partial mu agonist. So methadone was a full mu opioid agonist, but it is partial mu opioid agonist. It decreases withdrawal symptoms. Okay, and it is also kappa antagonist, where it helps to decrease dysphoria. Buprenorphine, unlike methadone, it can be prescribed in the office, in the doctor's clinic. Okay, you don't need to have a multidisciplinary team or inpatient setting for buprenorphine, unlike methadone. So buprenorphine can just be prescribed by the doctor in OPD or in his office. Again, it is used for opioid use disorder maintenance therapy, and can also be used for some pain. The good thing about buprenorphine is that ceiling effect on respiratory depression is seen here. So we said that methadone we prescribed in the hospital setting or in patient setting, because there is a risk for respiratory depression with methadone, as it is a full opioid agonist. But since buprenorphine is partial mu agonist, and with these symptoms it decreases the, with this quality it decreases the withdrawal symptoms. So there is also one thing, that it doesn't cause severe respiratory depression, so there is a ceiling effect. Okay, so hence it is safer, so the doctor can prescribe it office itself. It precipitates withdrawal if given too early, before COWS, that is clinical opioid withdrawal. So here you have to remember that the COWS score, the COWS is a clinical opioid withdrawal score, it must be 8 or greater than 8 to 12. Okay, and only then, when this criteria is fulfilled, then we can prescribe buprenorphine. Okay, so it says that buprenorphine can precipitate withdrawal symptom if given too early. That means if the opioid COWS score is less than 8 or less than 12, in that case, if we give the buprenorphine, then that can precipitate the withdrawal symptoms. So we have to wait until the COWS score is greater than 8 or greater than 12 before prescribing buprenorphine. Okay, yes, clinical, from examination point of view, it's a partial agonist. It is safer, it has safer OD profile, and start only when in mild to moderate withdrawal. So the person must have the score of 8 or above 8 or 8 to 12 brains, then only in that case we can use buprenorphine. Okay, next is Suboxone. Suboxone is a combination of buprenorphine and Naloxone. It is also partial mu agonist like buprenorphine, but it has also Naloxone in it. So the Naloxone components, it helps to deter the IV abuse. Okay, so Suboxone can be prescribed sublingual in an office-based setting. It is used for the treatment of opioid use disorder maintenance, and it is often preferred over monobuprenorphine. The side effect is same as buprenorphine, but the Naloxone component causes withdrawal if injected. So used in patient at risk for IV misuse, safer overdose profile. This we have to remember. Okay, now since Suboxone has Naloxone component in it, okay, so if you just give if there is a person and if you give Suboxone, let's say sublingually, then only the buprenorphine component works, but the Naloxone component doesn't work. But if you think that the person is taking IV drugs, okay, then in that case, if the person is taking IV drugs, IV opioids, then if you have been given Suboxone, then at that time even the Naloxone component works against that IV opioid, like heroin, that the patient is taking. So in that case, that Naloxone immediately cancels the effect of, let's say, the opioid taken in an IV form, and it produces the withdrawal symptoms. So because of withdrawal symptoms, the patient feels, instead of feeling euphoria, feels too much discomfort within themselves. So hence, in this way, Suboxone is given to those patients who has opioid use disorder, and now we are planning to put that under the maintenance therapy. At the same time, if you think that the person has increased risks of taking IV forms during this maintenance treatment, then you give this Suboxone, because the naloxone component there helps to deter the patient's craving for IV use. Okay, because it immediately precipitates withdrawal symptoms and patient cannot withdraw that. So okay, yes, now let's learn about naloxone. Naloxone is pure opioid antagonist. It is a competitive antagonist. We can prescribe it as IV, IM, intranasal, okay, forms. So intranasal, in community use, intranasal form is given, whereas in the hospital we can give in IM form. So it is used for acute opioid overdose, and it helps to reverse respiratory depression, CNS depression, and meiosis, which is opioid toxidrome. It can precipitate acute withdrawal, so we use lowest effective dose. It precipitates acute withdrawal. This is the side effect, yes. So re-narcotization, and also we have to know that sometimes re-narcotization is necessary. Okay, this we are going to learn here. Let's say the naloxone has a short half-life of 30 to 90 minutes only, so we need repeated dosing. We may need repeated dosing, and we have to monitor for re-narcotization, and if no response after 2-3 doses, consider non-opioid cause. So here what we want to say is that in case of naloxone, since it has got a short half-life, so if a person, let's say, has been taking some IV drugs or some opioids, let's say, and is now under respiratory depression, and if you give naloxone, since naloxone has short half-life of 30 to 90 minutes, once you give in the community setting, let's say intranasal form of naloxone, that naloxone, the person might come back to his or her consciousness, okay, because the naloxone is cutting down the effects of opioid. But again, since it has very half-life, the person may again fall back into the opioid toxidrome symptoms, any of the symptoms, like, let's say, may again go lose consciousness, may go back to a CNS depression, respiratory depression. So in that case, we again have to give the naloxone again. So that is what we say, that repeated dosing might be required. But remember, if you have given the repeated dosing for 2 to 3 times already, and even if that the patient is not coming, if there is no response with the naloxone, then we may have to think about non-opioid cause. Next is naltrexone. Naltrexone is pure mu opioid antagonist, and it is also long-acting. There is oral daily or IM monthly formulation for this. Key indication is that relapse prevention, post detox. Okay, so firstly, to be prescribing the naltrexone, the person must be opioid free for 7 to 10 days, okay, to prevent the withdrawal symptoms. So that is called post detox. So it is can be only prescribed post detox. And then if you do while you are taking the opioid drugs, when the patient is taking opioid drugs, then it causes withdrawal symptoms. So the patient may not want to take naltrexone at all, right? It's oral formulation, so it's very good and easy for the patient. Now the patient, if you give when the patient is taking opioid, they start feeling withdrawal symptoms, and they will not like to take the naltrexone. So for this, we have to wait for up to 7 to 10 days before starting naltrexone. So the patient must be opioid free for almost 7 to 10 days, and then we can prescribe naltrexone. And with this, the craving for the opioid will just go away, because as soon as if the patient will try to take the opioid, then naltrexone's effect kicks off, and then soon he or she starts developing withdrawal symptoms, and the patient will don't take the opioids. it is hepatotoxic at high doses, so we may have to check LFTs. Yes, this is important. And we also know that naltrexone can also help in alcohol use disorder and may help in nicotinic cessation also. Sometimes it also helps in naltrexone, not just helps in opioid but also in alcohol and nicotine cessation, and may cause weight loss. For USMLE point of view, methadone or buprenorphine maintenance is considered safe in pregnancy, but both reduce maternal and fetal complications compared to untreated opioid use disorder. Though methadone has more long-term data, so we often prescribe methadone for pregnancy. Methadone is, let's say, moderate to severe opioid use disorder withdrawal symptoms, then we give methadone. Methadone is always given in inpatient setting, and it is pregnancy safe. Buprenorphine, we begin buprenorphine after withdrawal starts, often in mild to moderate withdrawal cases, and it is safe for outpatient, so we can give in outpatient setting. Suboxone we have to stop injection misuse when we feel that the person may use IV forms during the maintenance treatment. So in that case, we use the Suboxone. We don't give Suboxone in pregnancy. Suboxone is often prescribed for those struggling with severe cravings and early recovery, while Naltrexone is suitable for those already detoxed and seeking to avoid relapse without further opioid dependence. So nursing considerations. NRT pads, gum, and lozenges. So rotate pad sites to prevent skin irritation. Instruct patients do not smoke while using nicotine replacement therapy. Gum, if you are using gum for nicotine replacement therapy, chew and park technique is used, where you chew until tingly and park between cheek and gum. Assess for headache and palpitations, which are the side effect of nicotine replacement therapy. With Varenicline, we have to take with food and full glass of water to reduce the upset. We have to monitor for mood changes, depression, suicidal ideation, as there is black box warning. Educate set of quit date 1 week after the starting. Okay, so you take Varenicline for 7 days, and then after 7 days you ask the patient to stop smoking. Okay, so if there is any vivid dreams or insomnia, you ask the patient to report to the doctor or nurse. Methadone is dispensed daily at licensed clinic. Observed dosing is required. Monitor QTC. Obtain baseline ECG for methadone. Assess for respiratory depression, and as it is a full agonist, there can be respiratory depression. Do not give extra dose. There can be risks of accumulation and overdose. Buprenorphine or Suboxone, let's say Suboxone is buprenorphine plus naloxone. Administer sublingually. Do not swallow. Wait until cow's score is greater than 8 before first dose to avoid precipitated withdrawal, especially with Suboxone. Monitor for withdrawal symptoms after administration. Educate is naloxone component deters IV misuse. Okay, nursing consideration, again we have for opioid antagonist and overdose management, naloxone or Naltrexone for emergency use. Administer IM, IV or intranasal per protocol. Monitor respiratory rate and oxygen saturation continuously. Duration shorter than opioids, so repeat dosing may be needed every 2 to 3 minutes. Watch for acute withdrawal in as that symptoms like agitation, vomiting, and tachycardia. Keep patient under observation for re-narcotization. For Naltrexone, confirm patient is opioid free for 7 to 10 days before starting, and this can be confirmed by urine and drug screen. Monitor for liver function tests. Naltrexone can be hepatotoxic at high dose. IM injection is given monthly, can be given monthly. It improves adherence, and educate opioids will not work for pain relief well on Naltrexone. Okay, opioids will not work because it is full antagonist, competitive antagonist, and uses non-opioid analgesics. So in that case, if the person is having pain, opioid doesn't work. When you're taking naltrexone, you have to take a non-opioid analgesic. General opioid disorder nursing is that I use non-judgmental therapeutic communication, assess cause score for withdrawal severity, educate on harm reduction, needle exchange, naloxone kit at home, screen for SBB, SCB, HIV, and IV drug users, refer to counseling and support groups. NCLEX priority, safety first. Respiratory depression is priority concern. This back for all medications, document pain scale and withdrawal symptoms, report suicidal ideation for Varenicline and Buprenorphine. Never leave naloxone administration undocumented. Now there are some USMLE questions here. In this question, I want you to pause the video here and go through these questions. These questions have been asked in USMLE examinations 1, 2, or 3. Okay, these are model questions, but this has been asked. So here you may have to find out alpha for beta nicotinic acetylcholine receptor. So it is somewhat like Varenicline, right? So Varenicline is partial agonist at nicotinic acetyl receptors. So you have to choose this. Here we know that for Naloxone, the repeated administration may be required because it has short half-life. So you may have to choose this answer here. That is called re-narcotization. Next is continue buprenorphine benefit also if in pregnancy, although methadone is the safer in pregnancy, but sometimes we can also continue buprenorphine. Okay, not the Suboxone or Naloxone, only buprenorphine or methadone, but methadone is better. But if the person has been taking buprenorphine, then is good with buprenorphine, then even buprenorphine can be continued in pregnancy. This is for NCLEX. In this question, notify the physician and prepare to administer another dose. Again, this is re-narcotization with Naltrexone. This is, I think, with Varenicline. You have to set a quit date for 1 week after the start of medication, and this is with maybe Naltrexone. Yes, Suboxone. The patient reports a count when we only prescribe this when the patient has a COWS score of 8 or greater. So with this, I conclude this very, very important topic. In this topic, the most important presentation for you for slide is this one. Okay, go through this. This is very important. And next important is this one. So if you are commanding these two, then you can easily do the examinations. Memorize it if it is necessary, but you are surely going to find this one of these questions in your examinations. Okay, with this I'd like to end this topic presentation. I will see you in the next one. Bye bye.